Like PCI just a little north, PVI has actually supplanted open surgery as the primary mode of revascularization for patients with peripheral arterial disease, or PAD, in the United States. So there's a paper, the March 10th issue, Trends in Settings for Peripheral Vascular Intervention and the Effect of Changes in the Outpatient Prospective Payment System. So to talk about this, I'm with first author Manesh Patel, who is a director of the cath labs across the Duke Health Systems, and he is also from the Duke Clinical Research Institute. Thank you very much for coming back and chatting once again. Now, PVI has really come into its own in recent years. I had not realized that it had actually kind of surpassed surgery in this setting.
Yeah, no, I think it's important. My colleague Skylar Jones helped lead this with me, and what we found was we looked at Medicare data across 2010, 2011, 2012, and we're able to look at trends in what's been going on in patients with peripheral vascular disease. And what's really impressive, I think, is that we've been able to get to a lot of parts of patients' bodies with endovascular therapy, hopefully for their betterment. And peripheral vascular intervention has certainly gone up significantly. And so what we've seen is a rise in revascularization of peripheral vascular intervention. And specifically, we've seen sort of a shift.
Yeah, because as of 2008, there was a shift in payment.
Yeah, right, exactly. So before 2008, we had data, and then after 2008. And the shift in 2008, the shift in payment, just to be clear with the Medicare sort of Affordability Act, it was to say that we want to capitate or try to understand how to lower costs. And so one of the things Medicare did is to say outpatient procedures would get a global payment if a revascularization procedure happened. And that global payment would be less than a hospitalized payment, hoping that, again, if patients can get outpatient procedures in a clinic setting, that they may be able to be cared for in a more expedited fashion and hopefully a safe fashion. What this has led to is a huge shift, an expected shift from hospitalized patients getting procedures to the outpatient setting. Sometimes unintended consequences occur, though, with all of these decisions. And so this shift has been so large that I'm not sure they're going to be saving money. That's one of the questions we're sort of posing in the article, is that with the reimbursement going to the outpatient setting and things like atherectomy or other procedures occurring, there's been such a large increase in the growth that we'll have to see if, in fact, that is the case. The second questions that come to mind immediately are who are doing these procedures. And so unlike other parts of cardiology, you might say, peripheral vascular interventions done by many specialties, which include radiology, surgery, and cardiology. And one of the features of the shift is that, in general, radiologists tended to be hospital-based physicians. And so the shift in these revascularization procedures has been predominantly driven by surgery and cardiology.
Yeah, I mean, you showed a 5-fold increase in PVI in office-based clinics.
Yes, and this is, the 5-fold increase in office-based clinics because of this global payment is certainly, from the perspective of a physician group, whether it's the surgeons or cardiologists, is a payment model that allows them to get the total global payment. Now, of course, they have to set up a way to do it safely, and it brings to questions of appropriateness and quality and outcomes, and we're still going to be getting these data coming forward with regards to how these patients did. So we are looking to hopefully have that information shortly. But there's been a growth, and I think, importantly, there are patients with PAD, as you know, almost 8 million Americans might have it, and they certainly have symptomatic lower extremity edema and sometimes lower extremity disease. And so we have to figure out, is it venous or arterial, and then improve their outcomes by hopefully revascularizing them so they can move more and avoid unnecessary sort of limitations in their movement.
I was intrigued a few years ago. I was talking to Mark Trucco because we had talked about atherectomy years ago in the heart, and it just kind of went nowhere, and suddenly it became fairly important in the periphery. Did you do any investigation or data about that particular procedure?
So an important thing about atherectomy, and I'll remind our audience, atherectomy is a procedure that can be done in several ways, where a device is taken into the vessel and it can either spin or directionally take out plaque or do several other ways to get the tissue out of the vessel. And for a long time, atherectomy has been used in the periphery. But what we found here was that, again, with the outpatient growth and payment codes being higher for atherectomy, we've seen a substantial increase in the use of atherectomy. So again, the questions will remain on how well is it being done? Is there really substantial evidence that much atherectomy will improve outcomes? But our data would say that in patients with PAD, these areas are growing fast. Endovascular revascularization in the office-based setting with use of atherectomy. And so from the perspective of the healthcare system, we need cost effectiveness and clinical outcome data in this setting.
So are you going to continue following the data?
Yeah, so we're going to certainly have Medicare outcomes data in this population, and we're looking at other ways of understanding their medical therapy and understanding their outcomes, not just from the cardiovascular sense, but from their limb sense. How did their limbs do?
Well, the paper is fascinating, and so I please take you off to the JACC issue for March 10th, Trends and Settings for Peripheral Vascular Intervention and the Effect of Changes in the Outpatient Prospective Payment System. And for CardioSource World News, I am Executive Editor Rick McGuire.